Butch and Bob Show.
World famous Butch and Bob Show here on WIFO 105.5 FM in Jesup, Big Dog Country Radio. And Bob, girls tennis team region champs.
Yep, our congratulations to them. They had a good year. So
Yeah, they did, didn't they?
Go far in state. Yeah.
And now they go to state in a week or so. All right.
Not sure about the date and time. As soon as we get that, we'll pass it along.
Okay, so the girls tennis team wins region yesterday in Savannah. And boy, I just couldn't believe that score that Wayne County had over Glen Academy. I thought they had a really good baseball program there at Glen Academy.
Yeah, it was our day yesterday. I said they had a good pitcher. Like I said, he's a commit to LSU, but we had his number yesterday. Blew him out.
Just blew him out. All right, sounds good. Well, we've got a guest in here this morning here on the world famous Butch and Bob Show. We have Dr. Grisez. He's a surgeon with Bone and Joint Institute. Good morning, Doc.
Gentlemen, good morning. Thank you.
How you doing?
I'm doing great. How about you guys?
Doing good. I think you were on here almost a year or so ago and talking about what you do at Bone and Joint Institute. I'm a patient of yours. I got a brand new titanium hip in my right hip a little over a year ago. Doing well with it.
That you do. You're a walking advertisement and talking advertisement for me, so I appreciate that.
Yeah, got that brand new hip. I mean, I got to the point where it was bone on bone. I couldn't hardly move, and Dr. Grisez put a new hip in December a year ago, not last December, but the December before. Just had my 1 year checkup this past December, and everything was looking good, and I appreciate the good work you did, Dr. Grisez. It makes a big difference when, it's amazing. I got a titanium hip, and it works just fine.
Right, and that's the great thing about hip replacement surgery is that the outcome is pretty quick. I've had plenty of patients wake up, in the recovery area and note, my hip pain, my groin pain, and there's a lot of, what exactly is hip pain, and for most patients it's going to be localized kind of in the front, their groin. That's where they'll say it hurts, and so they'll get their, we'll try some stuff, but for bad hip arthritis, the replacements, the surgeries now, it's a pretty swift recovery. Most patients by 6 weeks, I cut them loose. I say I'll see you in a year. No restrictions. When it's all said and done, you can go back to do whatever you like to do. And even after the surgery, I don't really give any restrictions at all. You can sleep how you want, lay how you want, put your leg how you want. We've really streamlined the surgeries now to make them, easy. No more days of spending 3, 4, 5 nights in the hospital, that kind of stuff. So,
I know. Mine was done in your office there in the surgical
Correct.
department there, Bone and Joint Institute here in Jesup. And what amazed me is when you said, well, after the surgery, you're going to get up and walk around with a walker. And I just couldn't believe that. But I did. I got up and walked around with a walker and then used it to go out to the car. My family took me home. And the next thing you know, I was out then for 2 or 3 days there. I was chasing grand youngins with my walker,
Right.
and through the house. And then after that, I was using a cane, then just regular walking. So that hip surgery was just something else. And, talking to you before I had my hip surgery, years ago, it was a lot more of a recovery time period. You had to go in the hospital, you had to do this, you had to do that, take more time recovery. But with today's robotics and surgery, modern surgery techniques, you're back up and at it in no time.
Correct. Really has changed to where, patients are up and moving immediately. In the days of, rest and recovery for hip replacement, I tell my patients, I want you up, I want you walking, walk. That's the fastest way to recovery with these replacements. And, you had it in our surgery center here, I operate, and I do, probably about half of my cases, as many as I can really, there in our surgery center, so patients can go home the same day. There's no, not a need to necessarily spend the night in the hospital. I do operate out of the hospital as well. We have an excellent outfit over there for my patients that, I don't feel comfortable that they should go home the same day if we need to watch their kidneys overnight, if they've got extensive heart disease, some reason that, just want to keep eyes after a big surgery like that. But for healthy patients, that are motivated, it's done the same day, you're up and moving. I do knee replacement surgeries as well, and the knees, the recovery for a knee replacement, it's a lot
more moving parts there.
There's a lot more moving parts. There's more you have to do physical therapy for the hips. I generally don't send my patients to the formal physical therapist, but for the knee replacements, you have to do it 2 to 3 days a week, at least the first 6 weeks afterwards. Most patients by about 12 weeks after their surgery, I would say are happy. They're glad they did it. You're not 100% yet. It really takes, even up to a year to get to your final outcome with your knee replacement. But they do just as well as the hips. You put them all together after it's all said and done. And patients that have knee replacements, patients that have hip replacements, very, very happy. It's why I do what I do. It's just because it's such a quick change in somebody's quality of life to get them back to walking, getting back to doing the things that they like to do. And in orthopedics, that's one of the things that we have to offer.
Okay, we've got Dr. Grisez in this morning, a surgeon with the Bone and Joint Institute, specializes in hips and knees. There's all, is the hips usually what you did with me? Put the shaft down into the femur there, and then put the new ball socket up in there. Is that most of your hip surgeries?
Most of the hip replacement surgeries are just that. We resurface take the ball is usually arthritic. We take the ball out. You don't need that ball anymore, and then I put a titanium socket in, a stem that fits into your femur, and then a new ball that sits on top of that stem and sits in the socket. It makes a nice smooth moving joint again. I take care of a large majority, as many of the county's hip fracture patients that come over to Wayne as well. And those patients, sometimes they need a hip replacement. Sometimes it's a partial hip replacement. Sometimes it's a rod and screws. There's different flavors of fracture surgeries that I do as well to repair those patients. I treat them very much the same way, though, as my hip replacement patients. I try to get them up and walking immediately afterwards, because in an older patient that falls and breaks their hip, if they're down for any amount of time, it's really, really hard to get back up and get going. So same principles apply. You get them fixed, you get them stable, you get them moving.
And that's what you did with me. After my surgery, you had me up walking. You gave me instructions on how much to walk each day with the walker, and then as soon as I can, go to the cane, which I did, and then without that, and I went to Garrett for my physical therapy, and he helped quite a bit with the instructions that you gave them, and it was just amazing that I have this titanium artificial hip in my right hip, and it just works just fine. It absolutely amazes me.
It even still amazes me that we have the ability to take out what you're born with and put in metal and plastic, essentially. I mean, it's good metal, it's good plastic. It's not cheap, but it really can recreate the function of the joint. And with the hips too. Now with the approaches for the hips, I do almost every patient from a front or an anterior approach. Some of it's been, pushed from marketing from the vendors and so forth as well. I was trained very heavy with an anterior approach replacement. Anterior approach, a posterior approach, a side approach, they all do very well. After about 3 months, you really can't tell a difference. Now, early on, I think there's a little bit better in terms of pain control, mobility, and so forth as well. And the way that I do it, I use an x-ray machine while I operate, so I can make sure I've got my implants where I want them. I can make sure I got leg lengths correct. So there's a lot of advantages with that. And then, I do a fair number of hips with a robotic-assisted arm as well. Doesn't need to be done for every case, but there's certain patients that have some, bad deformity. They've had hip dysplasia when they were younger. They don't have normal shaped hip sockets and so forth. And having some of that technology, I was also trained very heavy, tech heavy. So I like to incorporate when I can tech into my OR. It's it's just a different type of hammer. It lets me, if it gets me, a patient with that much better of an outcome, then absolutely, I think it's important to use.
A lot of people out there, and I was guilty of it also, put up with pain because you're scared to go get something done. But after my hip surgery, I was thinking, why did I put this off as long as I did?
The patients that do the best are the ones that sometimes you wish that they had come a little bit sooner to see you, and they get on the other side of it and wish that, I wish I had done it sooner. But the ones that perform the best are also the ones that tell you that. So sometimes hanging on, not to the dire end where you're not walking anymore, but the ones that, have been dealing with it for maybe a few years and have tried a few things. We'll try anti-inflammatories, different Tylenols, sometimes some therapy, some exercises. Occasionally we'll do some hip injections. There's some modalities that can get patients okay relief to let them do what they want to do. But when they get to a place where they say, Doc, I've just had enough, I can't do what I need to do. I can't walk with my youngins anymore. Walking the dogs has gotten, miserable. We canceled our yearly vacation, or I went on vacation this year and just sat in the house the whole time. that's not a way to live. And if there's a clear identifiable thing that can be done with it, the surgeries are good surgeries. They're generally low risk surgeries. It's surgery, so there's always risk involved and so forth. But, the outcomes generally are good. And we look every year when we compare, procedures that we have to offer patients. Cataract replacement or cataract surgery always comes there at the top. Hip replacements always within that top 5 too. So it's really revolutionized and keeping people walking until the good Lord calls them back. And that's my goal for every one of my patients.
Okay, Dr. Grisez in here, surgeon with Bone and Joint Institute here at Jesup and other locations in this area. Now, we've talked about the hip quite a bit because it's kind of personal to me, but you also work on, what kind of different work do you do on knees?
So for knees, I primarily do, first-time knee replacement surgery. At our practice, we have Dr. Velosin and Dr. Polander. Many of my patients have seen, or many patients in the community have crossed with one of them. They do a lot of we can call it knee preservation, like arthroscopy surgery, where you'll go in if a patient has like a meniscal tear or if they've got an ACL injury, and they'll do the arthroscopy or the camera type surgeries. When the patient gets to a point where, and they're generally a bit older, at least 50s, 60s and beyond, that have arthritis in their knee, then sometimes we'll discuss knee replacement surgery. Very similar concept to the hip replacement. We go in and essentially resurface the knee and put in metal and plastic implants to recreate a smooth moving knee joint. Knee replacement surgery is very good surgery, but like I mentioned, the recovery time on that is it's a little bit longer, and I think it takes patients about 12 weeks to get to a place where they say, I'm glad I did it, but it takes even up to a year to see the final improvement and benefit. Redo surgery, I do redo surgery as well. If patients that have had knee replacement surgeries, if they have issues with those, and there's something that is something that can be changed or something to improve. Usually that involves a pretty substantial workup from my end and the patient's end to make sure that we have a good, clear, identifiable cause of why the knee replacement they have is not, functioning well. And then there's options to sometimes go in and many times it involves removing the prior implants, placing new implants, and so forth. Many of those patients do very, very well as also. But I do tell patients, once you've had one knee replacement, that's your best shot of having a good outcome. When you start to get into the revision settings, I operate on ones I know I can make better, so I usually don't go in with we'll try. This is usually we're going to make a difference here, but getting those patients to 100% sometimes is a bit of a challenge.
Folks, if you do have knee pain and you just kind of put off going to the doctor, or hip pain, take my word for it. Don't live with that pain. Don't think it's going to get better or whatever. It's good to live without that pain, and just go see Dr. Grisez or at the Bone and Joint Institute for that, or any other the doctor that you want to on there. But you just need to get it taken care of, because probably the more you put it off, the worse it's going to get.
It's progressive. Arthritis in and of itself is a progressive type disease. X-rays never look better. I've never had a patient come back and say, "Oh, your X-rays look better today." And once you see arthritis on the films, it's there, and the symptoms vary. Everybody's symptoms progress at different rates. Some patients will tolerate, but bad bone-on-bone X-rays, but they don't, their pain is manageable, and others, where their X-rays are getting bad, and they've tried some things. Not every arthritis means a surgery. It doesn't mean a replacement. That's all quality of life driven elective surgery, and I make that decision with the patient. I tell my patients, I'm riding, I ride shotgun on this ship with you. You're going to steer it where you want to go, and I'm going to kind of help you make the decisions and make informed decisions. But we have tons of non-surgical options. We'll do, steroid injections. We'll do, the visco injections or the rooster comb shots, gel shots. We have options to do even PRP type injections as well. Physical therapy. We have a great outfit of our physical therapy office. Joe Hires is our head physical therapist, and we've got offices here in Waycross, so we'll get our patients into PT. There's some other newer things, nerve blocks and so forth as well. I use those for some patients too. We usually have a discussion about that type of stuff. Anti-inflammatory medications, braces. I've got tons of cards to play when somebody comes to me with a kind of a new onset knee or hip issues that haven't done a lot, and like I said, it doesn't always mean surgery. try to reserve surgery for that case where, we've tried this stuff, it's not working, it's not good enough, and then crossing the bridge at that point.
Now, with my hip, it was pretty well right there. They took the X-rays and said, but you got bone on bone. You're going to have hip replacement. But I've had back problems for many years, and I'm seeing Dr. Lameau at Dr. Bone and Joint Institute, and he did 3 injections over the last year, and probably sometime later this year I may end up having to have surgery on my back because it does hurt. But you do, just like you do and Dr. Lameau does, you do try those other procedures if you can before you go to surgery. My hip, you couldn't do that. It was bone on bone. I mean, you had to do that. But that's what y'all try to do. You don't just say, all right, I need to replace unless it needs to be. You try other techniques up to that point.
Correct, and I think it's always an individualized decision with that patient. There's some things that we can try for certain issues. Absolutely. When you get to a place where I don't have a lot of conservative options left, then yeah, definitely sometimes surgery becomes that one thing that I say, well, this is probably the only thing that's going to work. Dr. Lameau's a fantastic surgeon. He and I, we share a lot of patients. Hips and backs have lots of crossover and overlap and so forth as well. And I tell my patients when they come in, because many of them will have back issues, hip issues, and I'll say, if I send you to Dr. Lameau, he's going to say, Brian, take care of his hip. Take care of her hip, get the hip fixed, and then send them back over when you're done, and then I'll get the back sorted out. And the back stuff is a little bit more tricky to solve, but there's a lot of good treatment options for that as well.
And that's what y'all did with me. You took care. I was seeing both of y'all at the same time, Lameau and you, and Dr. Lameau and you. And Dr. Lameau said, well, get your hip taken care of with Dr. Grisez first, and when that's done and you got your 1-year checkup on that, then we'll start deciding what we want to do with your back. But up to that point, he did injections on that.
Correct.
We got Dr. Grisez in here this morning from Bone and Joint Institute. He specializes in hips and knees. But y'all do because if you have any questions, you can always text them in at 912-427-3711. Someone said, what about shoulders? You've got surgeons for that.
Correct. So we have 2 wonderful, fantastic surgeons for our shoulders. Dr. Velosin, who many of us know, he's been here in Wayne for over a decade now. He does a lot of rotator cuff surgery, labral surgery, and then Dr. Polander, who's a young guy like myself. He and I started about the same time. He's a sports fellowship trained shoulder surgeon and does the full gamut of shoulder surgery, rotator cuff repairs. He does all the shoulder replacements for the practice for either the arthritis shoulders, shoulder fractures. He's an excellent asset to us as well. For the most part, we're a full outfit practice. We will see anything that comes through the doors. We can take care of just about everything. There's some very limited things that sometimes we don't have the equipment or is a little bit beyond what our training lets us do, and we'll find we've got other colleagues in the region that can take care of those patients. But for the most part, if it's an orthopedic issue, we'll see it. We've got 3 fantastic physician's assistants at the front lines. We as surgeons, none of us, or at least if you find a surgeon that says they love to be in clinic, they're probably lying to you, because we like to be in the OR and operate. So we rely heavily on those physician's assistants to kind of stand in the front line and capture those patients, get them triaged. The ones that need to get in to see the surgeon quickly, they get them to us. If it's the patient that doesn't need a surgery, can be managed with some of that conservative type care, oftentimes we'll let them do that as well. But they're a huge integral part of our practice.
Someone texted in. They've said I've heard a lot about stem cell injections for various reasons. What's your thoughts on that, Dr. Grisez?
Stem cells, at least in my practice, depends what you're using them for. Now, if it's for like arthritis, hip and knee arthritis, when patients ask me about that, I say, unless you got $20 bills to drop out of your pocket, I don't recommend it. Now, if you do, I'll come behind you and pick those 20s up. You don't have to worry about it. There's a lot of active research in the use of stem cells, the platelet-rich plasma, or the PRP injections, which is done for tendonitis in the elbow, is really what it was designed for, and we're trying it in other places. The results are a mixed bag of data. Sometimes it can be hard to pick out which patient is going to do well with which injection. Although I think those are all important discussions to have if you've got these chronic issues with pain and tried some stuff and it's not enough. Sometimes one of those injections can be enough to get somebody over the hump, to get them feeling better. But again, it's sometimes a little tricky to point out who's gonna do well with something like that.
Okay, someone just texted in and says they've got, not me, but they said, I've got 2 metal shoulders and 1 metal knee from Bone and Joint and couldn't be happier. Highly recommended.
Awesome. I love it.
And the thing about it is you change people's lives when they're not mobile and they're in pain.
Right.
And you come along and you replace a hip, you work on a knee, you work on a shoulder or the back or whatever the case may be, and the pain's gone and they're more mobile. That changes a person's life. That's
why I went into orthopedics. That's why, I knew when you go to medical school and you're trying to figure out what kind of doctor do you want to be, it's you kind of divide it into, you want to be a surgeon, do you want to operate on patients, or do you want to go and work in a clinic and see patients? It's kind of the 2 broad categories. And for me, I always liked working with my hands. I'm a very hands-on guy. If you come over to my house right now, I've got half of it torn apart because I like to fix things and put things back together.
You be careful those hands.
Hands are very important, but I do all my own car stuff. I haven't had my car in a shop at a mechanic in probably almost 20 years because I just refuse. I'll do it myself. We just did, we did time and belt, valve covers stuff and all that not that long ago. But in any regard, coming back, I liked working with my hands. And then so when you start to look into surgical specialties, I'm an instant gratification. I like to see somebody get better quick. And so within orthopedics, you can take somebody that's got debilitating hip or knee pain. Within an hour or 2, you put in a replacement. They're up walking the same day, and they're going home, and they say, it doesn't hurt. I had a young lady that we did a hip replacement on about a week ago, and came in, the next morning after, she spent the night with me in the hospital, and she said, Doc, when's it going to start hurting? And I said, I don't know. It might not. And she came back and saw us yesterday and really, no issues at all. Just so happy and just walk in. She said, I have not felt this good in years. And those patients, that just tends to be the story. And they'll come back and they're very grateful. And for me, that's what I like to see. Take somebody that's really in a bad place, that's, really having trouble walking. They're at the point where they're miserable. And then like that, they're up and walking, and they're happy. And so it was a no-brainer of going into arthroplasty and doing joint replacement just because the quality improvement was so fast. Okay,
someone texted in, I'm not sure what they mean by this, but it says, what about static B nerve? That's what they have right there. What about static B nerve? I don't know what they mean by that. Do you?
Static B nerve. Static B nerve.
They may want to retext and have a little bit more on there. So
that one,
you got your fan club out there, Brian.
Yeah, I could take a hunch maybe with the static B nerve. I mean, the nerve stuff around like knee replacements. Mm-hmm. We can do what we call genicular nerve blocks, which are blocks that are done to the nerves that give pain sensation around the knee. I reserve that type of procedure for somebody that has tried like injections and has tried some therapy, has, otherwise not a good indication to have a replacement or another type of surgery for chronic type knee pain. They can be pretty good. I don't do those, but I have a couple of docs in the area that I refer to that'll do those for us.
Okay. Mm-hmm. All right. Someone texted in, Brian is number 1 in my book.
Love it.
See what you do to folks' lives like you did with me with my hip,
Absolutely. No, thank you.
And someone texted in, he says, I think you've created a new show for information with a variety of different type of medical doctors and or local businesses, what they offer. So basically what someone says, we need to get more docs on here.
Yeah.
Someone said on that static nerve thing, it says, what about static nerve? Is what they meant. What about static nerve?
How about sciatic nerve? I
wonder if
that's
probably
where
sciatic.
I wonder if that means sciatic nerve. So
that's what goes down.
Sciatica. So
sciatica.
Sciatica is the common complaint of somebody will say, I've got bad sciatica. Oftentimes that's referring to one leg. Sometimes both leg pain. Usually it goes down your buttocks, your butt cheek, down the back of your thigh. It can go down the calf, the front of the leg, and into the foot. Mm-hmm. Most classic presentation of what we call sciatica. What that means is that there's a nerve branch, usually in the lower part of the back, that's getting squeezed on. Sometimes it's arthritis pushing on it. Sometimes it can be a bulging disc creating
That's
that.
me, bulging disc.
Sometimes it can be ruptured discs. Different causes for that. And sciatica, almost every adult in the United States at some point is going to have some flare of back pain or some flare of a sciatic type issue. Most of them, if you give them time, will get better on their own with minimal intervention. Therapies, anti-inflammatories like ibuprofen, Aleve, exercises, being cautious with lifting and the way that you go about doing things and so forth as well. If they don't get better, then there's a lot of options. Injections sometimes are enough to get those better, and then if there is an identifiable cause, then even small procedures can be done to relieve pain from that issue.
All right, got Dr. Grisez in here from Bone and Joint Institute. They're blading them on their spell check. They're trying to put sciatic.
They're trying to put sciatic, yeah.
Yeah, they're trying to put that in there, but it keeps going to static.
Autocorrect on my phone. I know that pain. Yeah, exactly.
Yeah. I love getting birthdays in sometimes in the morning. You can tell people talked into their phone, because it comes up all kinds of weird. And I have to sit there and try to decipher what we're really trying to say.
Yeah, Siri and I have disagreements all the time over what's coming out of my mouth and what she thinks it is, but...
Oh, Bob, any questions or comments for Dr. Grisez this morning?
You mentioned you work with the hospital as well. I heard a lot about the robotic surgery. Talk about that.
Yeah,
so that's a big asset to the hospital.
The robotic surgery is I was trained very tech heavy. Meaning that we use a lot of technology. I trained with one of the guys that did one of the first partial knee replacements in the United States with the robot. I do partial knee replacements as well. I might as well give my dig for that too. But I actually have two robotic platforms. I have one in my surgery center, and I do have a second robotic platform at my hospital. The robot for me is a different type of hammer. I would say that is it better? It's hard to say better. There's not great data that we can lay out and say, the robotic knee replacement or the robotic hip replacement is better than a conventional or a manual done knee or hip replacement. I do all of my knee replacements with a robot, with some type of robot assistance. And the robot's not doing the surgery. I'm not out drinking coffee while this thing's whittling away. Essentially, it's a way of me cutting bone very precisely. It's a way of me getting a lot of data from the patient live so that I can figure out where do their ligaments, and then this is getting in kind of the weeds of knee replacement. Basically, you want to put the knee replacement in so that the ligaments that support the knee replacement are balanced, meaning the rubber bands on each side are tensioned exactly the same. And that robotic technology gives me the ability to collect that data while I'm operating, adjust implant positioning, cut bone very precisely, put those implants in, and recreate where those rubber bands should be. And then I have, for me, it's if I can balance that knee so that the patient's knee moves and feels the way that it should, then those patients are going to be happier long term. But we don't know 10, 20, 30 years out how those robot replacements are going to perform compared to the ones that are done conventionally, because we just don't have that long-term data out. But that technology, having that available, you don't see that in every small town. We're not a big area, right? We've got a great hospital, not a big hospital, but a great hospital that has all of this technology at its fingertips, that you don't have to drive to the big city. You don't have to go to Mayo. You don't have to go, all the way up to Savannah or beyond, or even to Atlanta to get that robotic replacement. And it's here. We do it here. I was trained how to do it. I trained at big institutions. Capturing those patients and keeping patients, and I've seen that kind of change in the 2.5 years since I've been here. Patients that have had a knee done somewhere else, where they're coming back for their second one with us, which is nice.
Just a great asset to have at the hospital.
Right.
How do you determine if you're going to do the surgery at your location or the hospital? How's that determined?
So I've got some hard criteria for being a same day patient or going home the same day. If you are relatively mobile, meaning I don't like you to come in a wheelchair, but you're walking on your own accord with no more than usually a cane. You've got good support structure at home, and you have to have help at home, family member that can be with you for a few days. minimal in terms of medical comorbidities, meaning you don't have a bad ticker. Your ticker, don't have congestive heart failure. You're not on dialysis for your kidneys and things like that. Most patients, even the ones that have got sleep apnea that are insulin-controlled diabetics, are still good candidates to go home as long as that stuff is well controlled. So, and then I usually like to ask my patients. Some are, I tell everybody heals best at home. Trying to get home as quick as you can, you're going to do the best. And the patients that are motivated, if they want to go home, I let them go home. The ones that I think are good for it, I offer it to. But anybody that says, Doc, I really don't think I want to go home the same day, I just don't feel comfortable doing so, I don't push. If you need to spend the night at the hospital, you spend the night at the hospital. The outfit we have at the hospital is excellent. The nurses take great care of my patients up there. We've got a very well-trained team of nurses, OR staff, I would tell you, my patients, they'll tell you either way, if it's done at our surgery center, done at the hospital, I get nothing but compliments on both ends about how smooth the procedure and the process was.
Okay. Dr. Grisez in here this morning from Bone and Joint Institute. Anything else that you'd like to add before we wrap up the show this morning, Doctor?
Just come and see us. Don't let that bad hip or that bad knee keep you from doing what you want to do. I oftentimes at least see a patient a week that says, I wish I had come sooner, or I didn't know. I didn't know. And just, it's a question. If you don't necessarily have to, come, first off to see us, raise the question with your primary doctor. Say, I've been having some hip pain or some back pain or some knee pain. What can we do about it? We're here. We get our patients in quick. We have plenty of same-day appointments and openings. And definitely make the phone call. Come and see us. We'll talk. We've got options. Don't let the pain keep you from doing what you need to do.
Don't let fear keep you away.
Yeah, absolutely.
Just go to them, talk to them, and get a consultation there, and they'll let you know what they can do to help you.
Absolutely.
All right, Doctor. Good talking with you again.
Perfect. Thank you, guys. Appreciate you.
Have a good day.
Definitely.
World famous Butch and Bob show here on WIFO 105.5 FM in Jesup, brought to you by Murphy Builder Supply, by the Service Department of GNS Auto Sales, also brought to you by First Southern Bank and Heron Aldridge Insurance.